All right, let's get started here. My name is Aaron Hamilton. I am our moderator today, the chair of Identity North. I am super thrilled to kick us off here with a really interesting discussion. I had the opportunity to meet with Eric and Balraj over the course of the last few weeks, and talk to them a little bit about some of the interesting changes that are taking place that are, really impacting the way that we approach healthcare systems here in Canada. And I have to say, I'm really excited that we're going to be able to have this broader conversation here with the community. So the structure today is going to be a little bit more open and freewheeling than we've had with other webinars. Balraj and Erica have some prepared material. And then we're going to open it up and ask for contributions and feedback and thoughts from the community. So with that in mind, I'll ask you just to hold maybe your initial thoughts or questions that you might have, and we'll dive into that in a structured part of the event closer to the halfway through the session. So with that, I'm going to just explain a little bit about what's been on my mind with regard to healthcare and how we're bringing it. It strikes me that the world of healthcare delivery is relying on more and more specialized teams to evolve and to be responsible for us getting great healthcare. And I've been lucky, knock on wood, not to have to kind of draw too much upon the healthcare system, but I know a lot of friends and family that are. And as I hear about the stories of the teams of who they're having to deal with, it strikes me that there's more and more data being created, and that data has to get managed, and the access to that data has to get managed. And it's really important that the data kind of sit as a cloud around the patient, and that it's available to be accessed by the right teams at the right time, but only by those folks, obviously for privacy reasons, mostly that it gets locked down to only those that should have access to it. But the management of that control and that the sharing of that data is getting harder and harder to manage. And it strikes me that there's a lot to talk about here and a lot to solve. So with that, I'm going to turn it over to Balraj, who helped facilitate and bring us all together, and ask Balraj to kind of kick us off today and tell us where how he came to really care about this challenge.
Absolutely. Aaron, thanks so much for the introduction, and I'm super excited about this conversation with Eric and yourself, and to actually drill into the growth of the health data that's happening across not only Ontario, Canada, North America, and globally. And so, with that, what we wanted to focus on today, and I'll flip to the agenda slide, is talking a bit about the underpinnings of a patient-focused healthcare across Canada and North America as it pertains to healthcare organizations, building out a data governance framework and a patient trust framework as well. And again, I'm pretty excited to have Eric Sutherland here from the Canadian Institute of Health Information to join us through this webinar. As we explore the work that his organization is doing and what he is doing specifically to build out the blueprint for healthcare organizations across Canada to maximize the value and effectiveness of their data. So we're going to cover three broad topics here. One being building out a data governance strategy. The second being the intersection of patient identity and unlocking health data. And the third being building a patient trust framework. Short introduction, Balraj Dhillon. I'm a director at Simio Solutions on the engagement and delivery team, focusing on identity and access management solutions for private and the public sector. Prior to coming to Simio Solutions, I was at eHealth Ontario, working with their identity and access and data access side on the product management team. I've also led a number of solutions outside of the healthcare domain for payments in the telecommunications industry. When I started at eHealth, I think for me, it was just a aha moment. This is a space that I really want to be in. And so while working at eHealth, I also had the pleasure of meeting Eric. And I'll hand it over to Eric to do a short introduction.
For sure. And sorry if my voice is a little raspy, still getting over one of those, nasty summertime colds. My name is Eric Sutherland. I am a reformed banker in that I spent 20 years working at a major financial institution in downtown Toronto, where I developed a very strong passion for using data and information most effectively. And I decided a few years ago that while I had this passion for data and information, that I really wanted to apply it in an area that would have more meaning. And so I jumped from banking in the financial sector over to healthcare, where my first role was actually with the Ministry of Health in Ontario, where I was accountable for the Personal Health Information Protection Act, PHIPAA, which is the act that regulates all the various privacy practices in Ontario. And subsequent to that, I joined CIHI last year, taking on a role to understand really how do we mobilize data and information in Canada more effectively, while obviously continuing to protect the information as is appropriate. And so I'm happy to talk about this today. I've been hearing a lot as I've been touring the country. I'm happy to share what I've heard, and I'm happy to engage in this conversation because I see that specifically the work that both IdentityNORTH and the work that Simio is doing is being crucial, the types of things around identity management specifically, to actually moving things forward in the country.
Thanks, Eric. And I think that's a good point to kind of lead off on in terms of, the underpinnings and the frameworks that will really allow us to achieve real innovation in the healthcare space. I think that's a good starting point. If you could, kind of talk about what you're doing specifically at CIHI and some of the conversations you've had with healthcare organizations across Canada.
Sure thing. So for context, so my job, as I frame it, is a bit odd in that it is to work with healthcare organizations about what practical things do we need to do in order to mobilize data and information better. The work in and of itself started actually with the conference that Kai independently have been setting up last October, which is bringing together privacy leaders across the country. And through those conversations, it was widely acknowledged that technology can largely do whatever it is that we want to do. Legislation, for the most part across the country, allows us to do whatever it is that we want to do. There's a couple of areas that are grayer, but for the most part, to do the basic things that we want to do in terms of using data, it's possible through the legislation. So the challenges that we actually have are largely about people understanding what it takes in order to do this work, our processes, designing them in order to actually have the greatest effect, and aligning with the intent of how to use data and information better, and the will to actually get it all done. So that was what we heard last October. Subsequent to that, I literally have visited every province in the country and talked to every territory to really listen for what are the practical things that we could do. And with that, starting to come up with a general frame for how we can actually operate together. If I dial it back for a sec, like the number one problems or the two main findings that I had is that there's pockets of excellence that exist everywhere in the country and which demonstrate the value of data, that by investing it, you can actually get real returns. The problem that we have is our ability to scale and share. Many years ago, Canada was coined as a country of pilot projects, and we continue to be a country of pilot projects. We have not solved the nut about how to actually work together more effectively. And so my biggest aha and realization through the listening that I did was that if we create a framework or rubric for this is how we can have a common language for how to talk about this stuff together to actually make it easier to share capabilities together, then we'll actually be able to advance everybody and we'll be able to more effectively integrate. The second thing, which is adjunct to that, is we need to be educating the health leaders that are making decisions about investments in these things, that data is hard. It kind of seems silly to say, but this work is hard. We've been working at this for, I have evidence for up to 50 years, being aware that we need to be doing stuff in this space. Yet we haven't cracked the nut about what it is that we actually have to do. This is really, really difficult, but it is possible to do it. And we just have to believe and have the resilience to say, this is the right thing to do, what needs to be true in order for it to happen. Obviously, one of the things in that is, in order to be able to integrate the data, the various data that we have across the country together, is you need to have a common method for actually linking the data together, which obviously ties directly to the aspects of IdentityNORTH and the work that Simeon was doing. And so I see it as very complementary. I'm worrying about what we've got to do, and what these are bringing together are some of the practical tools and the how we could actually do this. So from my perspective, it's interesting and exciting time to be thinking about this, to really, how do we enable this better for everyone? I'll say one other thing, which is really around like using data, and obviously privacy and security is paramount as we talk about all of this stuff. But we also need to think about what are the balancing points between, and this is again what I heard from across the country, we need to think about what are the risks of sharing data, and how to mitigate those risks as most effectively as possible. We also need to think about the risks of not sharing data and not integrating it together across platforms and having an easy way to actually link those records together. Because while harms can be created by sharing the data, harms can also be created by not sharing the data. And as a healthcare system, if our objective is to minimize the harm, we need to think about both of those aspects in concert together. And that's again why having the tools to make it easier to actually realize that value, to minimize the harm of sharing data, is actually, I think, going to be one of the really interesting things as we venture into the next wave of this work.
Yeah, and that's really interesting, because I think as we get into our discussion today, we'll talk, about how a patient can manage their data, and how we put together, solutions that allow a patient to decide when they're sharing data, when they're not sharing data, and who they're sharing it with. Mm-hmm. So that'll be interesting. I'm just going to jump to the next slide here, which kind of talks about the entire health continuum, and talks a bit about what the frameworks exist. So before we do that, I liked one of your points that talked about it's a conversation that probably hasn't taken place around the policies, and what decisions and what information our leaders need to build out a go forward strategy. The challenge that I've always heard is that we have a technology challenge. It's a interoperability challenge. Did you hear those types of conversations across Canada when you were kind of doing your tour?
I would say many people through the conversations referred to a few years ago, the problem felt like it was technology. The current tone is that the problem isn't technology, it's our ability to use it more effectively.
Right.
So it's really separating, and this is the bigger insight, I would say, separating the notion of technology and the data and the information that are enabled by the technology. So where our problem lies is in using the data and information. If I go to a simple example, if I'm using an iPhone or if I'm using an Android, it shouldn't matter. Those are the technologies. But the data on those platforms should be integratable, or more to the point, my data from wherever the health record for me resides should be consumable by either an iPhone or an Apple or an Android platform. The technology should be agnostic, but the data and information, that's actually where the challenges are. And while many would say, well, we have interoperability because we have tools like FHIR, for example. What FHIR allows us to do is to exchange bits and bytes between systems in an effective and efficient manner. But if one system is speaking German, say, and another system is speaking Swahili, what it allows us to do is take the German language and put it into the Swahili system. Doesn't mean that system actually understands German. Yep. So we still have to have some ways to have semantic interoperability, and translating what the meaning of the data is between the platforms, so that way it is useful when it is transmitted. By ourselves and moving in bits and bytes, but other work is necessary in order to actually exchange the meaning of the data. And that's where areas like data standards, logical data models, conceptual data models come into play. And simply some tools like SNOMED, ICD, like they address some parts of this, but it doesn't address all parts of it. And there's some aspects like identity, which are not specifically prescribed in those standards, because those things are about the medical practices, not about the more general identity practices. Some standards in that space would be enormously useful for everyone to adopt, not only in healthcare, but also outside of healthcare, as we start to integrate in other data sets as well.
And that's a good point. And I think that's a good segue into kind of talking about, what is a future state? So I want to drill into, a bit of what the healthcare continuum looks like. But this is an interesting point that I think you and I were chatting prior to getting started here is, what is a future state? What type of innovation can be had based on the healthcare data?
Wow.
Big question.
Giant question. The way it's framed here, and even the way that Aaron talked about it in the first place, if I conceptually can envision that my health records are in Ontario or in Canada, if there are 14 million Dropbox equivalents or 35 million for all of Canada, Dropbox equivalents where all my health information is stored, and then I have the ability to say, I want to actually provide access to my data to these people for this purpose, that's fantastic. Now, I, however, am going to put on a little caveat on top of that. There are some aspects, because we are in a publicly funded system, where we need to have a conversation with health system leaders and the public about where using this data to improve the health system itself is actually of everyone's benefit. Determining, as I sometimes put it, there's a super bug in operating room number 2, that this is where population growth is expanding rapidly, and so we want to be able to put the next hospital, next healthcare facility in a particular location. That we actually want to use data in a fully anonymized fashion to be able to identify these are leading practices for improving care for individuals with multiple sclerosis or diabetes, or even identify people who may be more prone to developing diabetes in 5 years, so they can start to actually develop programs now to have healthier practices to prevent them from getting there. And using data for those purposes are actually in the public interest. And so finding what that line is between where the public should have full autonomy in determining where and how their data is used, versus there are cases where maybe we may say this is actually in the public interest, so we will use the data in this way, unless you say no. There should always be a unless you say no caveat, but there might be something, for example, in Australia last year, they developed a digital health record for the country, and one of the things they did, they opted everyone in and then allowed people to choose to opt out.
Right.
And they were admittedly disappointed when 10% of their population chose to opt out. To which my perspective is 90% are in. That's pretty darn good. And I would submit that of the 10% that opted out, when they see the value that the 90% are getting out of the use of their health records, many of those will choose to start opting in as well. So I'm not advocating for that specifically, but it is the type of thing that other countries are doing in this space, envisioning how things could actually work. And I'll use another example in Finland, where not only they have a fantastic a very interoperable system where individuals have access to the audit logs of their records, so they can see who has actually looked at their health records. So if they go into a medical appointment and they see the doctor they're meeting hasn't looked at their records, the patient then questions the doctor, why didn't you look at my records? You are wasting my time because you didn't prepare for this appointment. I'm ready to meet with you. Why aren't you ready to meet with me? Which actually had an overall impact of increasing the usage of EHRs across the entire ecosystem significantly, which I just think is a fascinating story in and of itself. But again, that's only possible if you have interoperable records where patients have access to the types of data about what they're doing and what is being done with their records.
Yeah, no, it's funny. That reminds me of a title of an article that I read, or I think it was a book. The patient will see you now, the other way around.
Nice.
And where patients are actually leveraging that information that's available to, take a more proactive stance in their care delivery as well, which is good. Good. So let's drill in a little more and talk about the different healthcare organizations that can benefit from the growth of this data. And so we obviously have your primary care doctor, and we have healthcare organizations, and there's other folks like emergency EMS services that can benefit of pharmacies, and connecting all of these different folks who are all focused on your care delivery is a big task that I think is slowly coming together. We have initiatives like CHI's Prescribe It, where they're trying to connect all the pharmacies across Canada.
Canada Health Infoway. Acronymizing.
Okay, Canada Health.
Just in case.
There you go. Okay, and then some of the regional viewers. So it's going to be interesting to see how some of this comes together. Have any of your conversations extended beyond healthcare organizations? Have you chatted to folks in the public healthcare system as it pertains to health data and the growth of health data?
Well, absolutely. As I was thinking about before, in terms of the areas of public health and population health, and the overall objective of moving to wellness as a metric rather than how do we treat those who are sick, as opposed to how do we prevent people from getting sick, and how do we ensure and improve an overall wellness of society as a whole in Canada. So that's one of the things as an overall theme, potential directions that I was hearing as I was touring the country. But if you're going to think about overall wellness, it ties to not only the entire continuum of care across your pharmacies and drugs and labs and various healthcare venues. It actually goes beyond healthcare to education, financial wellness, financial literacy. It even ties to the environment. I imagine a world where I have an app on my phone that integrates the fact that I'm an asthmatic, and that today, because of the temperature it is outside and the humidity level and the air quality index, and because of the amount of water I've actually had today, that it's probably a good idea for me not to be walking for 2 hours outside. And maybe I need to get inside and rest, so that way I don't pass out in the street. All of those tools to integrate all that stuff together are absolutely possible in the context of the apps and tools that we have today, and the watch that I'm wearing as I speak. But we need to actually integrate that together in a way towards that aim of what is it that the patient and the public are demanding.
Yeah.
And I try not to say the patient, because my focus is really on the public, because as soon as we say patient, that means that they're in the system and using it. I think of the public, because ideally we want to not have people using the system.
Yeah.
I don't mind using the word patient if it's in the context of you're always a patient through your life, no matter, but our objective is to keep all of the patients well.
Yeah.
Because wellness is really the objective in my mind.
Absolutely. And so when we take a look at it from a data perspective, and, just bringing it back to the theme of the conversation, the wellness is a really good topic to talk about, because the ability to integrate additional data sets outside of your blood, your x-rays, there's a wealth of information that's available. Are healthcare organizations across Canada in a position to start integrating these additional data sets so that you have a good comprehensive view of the public?
Simply put, no. But some of the challenges that we have in this space, there's the data that is governed by the publicly funded system, which largely relates to many of the things in the picture around acute care, emergency services, diagnostics, imaging labs, et cetera. But there's the adjunct health services, like your massage therapists, psychotherapists, psychologists, naturopaths, and other such things. How do those individuals get integrated into the system? And then there's all the second order things like social services networks and mental health networks and other such things. How do they get integrated in? while there's increasing talk that we need to be thinking of things more holistically, I'm not seeing the driver as much, the vision. Mm-hmm. Although I will say, and there was a report that literally came out yesterday in Ontario from the the Premier's Committee to End Hallway Medicine, I believe, chaired by Ruben Devlin.
Yeah.
And it was their second report, and part of the report was actually talking about these are the things we need to do. We need to be investing in digital technologies and some of the challenges and things they have to do along the way. So I'm hopeful that there are some organizations that are starting to lay out a bit more of a vision for where we want to be going. And then from that vision, we can start to anchor down, well, what needs to be true to realize that vision? And part of what needs to be true is integration across more than the domains we have now. Simplest examples I can give, anecdotally, I think it's certainly less than 50%, it might even be less than that, of the determinants of an individual's health are actually managed by the publicly funded system. Most of the determinants of health are outside of certainly the publicly funded health system, which ties to education, financial, but also the things like psychology, mental health, massage therapy, and all those other things as well. So we need to think about how, if our objective is wellness, then how do we get there? And part of it could also be empowering patients as the Sherpa of their records, inclusive not only of their health records, but also of their non-health records, but then having that integrated view, the patient, the public, has the integrated view of themselves, and then can share that fully integrated view with whomever it is. But that's only possible if they have a common view of their own identity.
Yeah. No.
See, I'm always bringing it back.
Bringing it back to the identity piece.
Yeah, that's true.
Awesome. All right. I'm just going to move on and, talk about some stats here in terms of interoperability and the opportunity for patients to leverage their health records. 46.2% think that mobile health will improve outcomes and treatment. So, Eric, this, I think, speaks really well to what you had kind of indicated, that there's a lot that, the public healthcare system can do, but there's a lot that is outside of the public health in terms of digitizing health. 43.4% believe mobile health will improve their self-care. And so there's a ton of apps that are out there that allow for patients to manage, chronic conditions and things like that. And so, again, tying it back to the identity piece, a lot of these applications are siloed. They're not integrated either with the electronic healthcare system and from an identity perspective as well. So it's a bit of a challenge kind of for healthcare organizations and folks that are policy and decision makers to really have a comprehensive view on, what are the levers they need to pull to improve public health. 42.8% believe mobile health will slow down the increase in healthcare costs. And it sounds like, the report that was out yesterday by Ruben Devlin kind of talks to that in digitizing technology and ending hallway medicine. And, that's an important driver, I think, not only in Ontario, but across Canada as well. 42.6% believe mobile health will improve interactions between patients and doctors. So I think all of these stats kind of speak, to the opportunities that exist around digitizing healthcare technology and making it available to patients, but also the circle of care. Eric, one question I had, for you.
Before you dive into that, Balraj, I wonder if I could ask you, are you struck by the fact that none of those numbers are over half? And also, I'm wondering if part of the problem might be this nebulous definition of what is mobile health.
Yeah.
No, I actually think that's a very good point, because up until today, mobile health from, I guess, patients and citizens in Ontario has been non-existent. I know that there's been, some POCs that the Ministry of Health in Ontario has launched in terms of getting health records to patients. But I don't think, we're even at the cusp of innovation, at the cusp of, allowing patients to maximize mobile health. So I think, Aaron, you nailed it in that this is still very early on, and patients may or may not be aware of the innovation capabilities for mobile health.
I think that's a very good point.
Yeah, Eric, go ahead.
Yeah, so I was struck by two things here. One, it's pretty much all the same number, so that means that 40% of people are convinced and 60% of people aren't. But I think that my main lesson, because I personally fundamentally believe the answer to all four of these questions are a strong yes. I, like Aaron, was surprised the numbers were as low as it is. But I think this is in part why it's so important to improve the data analytic and digital literacy of the public.
Yeah.
And I talk about health systems leaders and the people who are making the decisions, but it's also of the public themselves. If the public knew what capabilities existed, if they generally knew about the things that are happening over in certain parts of Europe, in particular, like the NHS and Finland and Estonia and Australia, et cetera, if they understood how far behind we are in many ways, then they would probably say, what do you mean we don't have these tools and technologies? Yeah. I don't think that we're not that far behind, but we do need to, we have an opportunity to step on the gas here. And I think getting the public on our side, getting these numbers well above 50%, which I'd even say makes it more of an election issue, then it might actually be to our benefit to say, you have to be investing in these tools because these are the things that actually will be the force multipliers to actually bend the cost curve of the overall health system, rather than just investing in where we've invested things for the last 50 years. These are new tools and new capabilities. We need to be investing in them because they can have the impact of materially improving care, as well as efficiency, as well as effectiveness.
I want to dig to one point, Eric. We've talked more about the healthcare organizations, and we started talking about the patients and what they don't know about certain technologies that will really improve their health outcomes. Is there work that your organization's doing to inform citizens across Canada about different stats and technology that can better their health outcomes?
So I'll separate that out a little bit. So what the Canadian Institute for Health Information does, we do create comparative statistics around various aspects and indicators in healthcare across the country. Usually things like, usually about medical practice, things like wait times, particular prevalence of various conditions, costs of healthcare in various provinces. It doesn't actually drill into areas of mobile care, et cetera.
Got it.
Groups like the Canada Health Infoway, they've been doing annual surveys for the last few years to understand what some of the public sentiment is towards the uses of digital technologies are. And some of those reports are actually very telling. And you can actually see over time how the belief and understanding and say the literacy of the public in using data technologies is increasing, but it's still not where it could be if we actually had more wind. I don't feel like we have wind at our back yet, and we need to get to the point of having wind at our back. So I think that there's opportunities for to understand and really listen to the public, and through groups like Patients Canada and the Patient Advisors Network, really listen to them about this is what the public is actually looking for, and what the public needs in terms of messaging. This is how your data is protected. This is how your data is actually being used most effectively to improve the system. And not the system is a cold thing. This is how this data is being used in order to make a healthier system for your kids and your grandkids and your neighbors and yourself. Like that's the type of messaging that we need to have some sort of program around it. If anybody on the call is in that space, I'm interested to have a talk with you about it, because it is one of the areas that I think some more energy and time needs to be spent.
Nope, completely agree. And I think that's a good.
It's actually a good time to remind people, if you should see a Q&A button on the bottom of your screen. If you click on that button, you can submit questions to the panel to discuss.
So Eric, you kind of touched on expediting the growth of these tools and, getting the wind on our back. And so I think the patient trust framework that, Simeo is working on, specifically from a healthcare perspective, really allows us to leverage the data and, maximize an individual's identity to make that innovation happen, those digital tools happen as well. So dig into that a little bit. And so we have the patient at the center here. And, what we're really working towards is, how do we have a verified patient identity? And this is a similar kind of challenge that I know DIAC is working on, and the folks at IdentityNORTH. It was a really big theme this past month when we had the IdentityNORTH conference. And we had heard from a number of speakers within healthcare and outside of healthcare, advocating for the need for a verified identity to allow for that innovation to happen. And so that's, kind of what Simeo is working on as well. And the other piece that goes hand in hand with that is, the interoperability and the ability to leverage that health data. And so throughout this, conversation with Eric, we heard about, the growth of that health data, that, really this is and is not a technology problem. The technology exists to integrate different data sets. There are standards that exist. And it sounds like this is, also a policy discussion that needs to take place, so that our leaders within the government really understand where technology is taking us within the healthcare space. But not only that, I think, the other thing that we really need to focus on is the consent management framework. Who can access my information? When can they access my information? How can I block individuals from accessing my information? And this more pertains to healthcare providers and ensuring that, patients have their privacy, which is adhered to, and we're taking our best foot forward here. Eric, we're actually on the policy side, on the consent management side for the Ministry of Health in Ontario. And so this is a growing discussion, not only in Ontario, but across Canada as well. Is there anything you would want to share on the consent management side?
Well, consent is tricky. And the simple way of thinking of it is, patients should have full right to decide who gets to access their records when. But then I would say, what if the person is unconscious going into the ER? Should those treating physicians have the ability to access their records? Right now, there are actual blocks that say, no, they can't.
Yeah.
Which can literally cause harm to the extent of death, which is tragic. And so the understanding where it makes sense to have consent, but part of this, and this is actually something that the federal Privacy Commissioner said last week, was that he was thinking less about, consent is certainly part of the picture, but part of the picture is also related to transparency and accountability. So when you are using health data, I am transparent that I'm using it. I'm accountable for not re-identifying an individual. Or if I am re-identifying an individual, it is for the purpose and express benefit of that individual. Yeah. So again, another example is, if I'm a primary care doctor, I have a really complicated case in front of me. I know one of my friends deals with autoimmune diseases all the time, and I want to do a data consult with them. Then is it appropriate for that patient to always give express consent for that? Or because it's in the interest of the care of the patient, should that have their express consent or not? And I'm not saying it should or shouldn't, but I'm saying that's a question that we should be asking. And so it may be the case that in the context of a consent management framework, there might just be a highest level, it might just be very broad brush levels of consent around usage of my data for care of me, of myself, usage of data for care within the context of health systems uses, and then usage of my data in the context of private enterprise, moving things forward.
Yeah.
And in all those cases, it might be more bucketed like that. I've seen some things, and this goes to permissions and policy manager you're talking about, where there have been very fine-grained consent, whereas I, as an individual, can say, I consent to this person in this facility having access to my data, which is fantastic power for me as the individual, but it can cause massive challenges in the context of the system itself, both in the context of providing care for the individual in a reliable way, and also the administration and the cost of actually doing that technically in the background in terms of the impacts of performance and such things. And so the simple answer may not be the most practical answer. And so again, it goes back to a conversation. We have to have a conversation meaningfully with the public at large in this space so that we understand what makes sense. So they understand, we understand what their needs are, they understand what our needs are, and then we work together on what is an appropriate solution that works for everyone. The assumption of the simple solution, detailed express consent everywhere, easy to say, hard to do, need to find a finer thread and a better line on that.
Yeah, no, and I'm smiling here because, you know, I was on the technology side trying to implement some of these consent management solutions at eHealth Ontario, and I know you were on the policy side. And so the short is, it's an ongoing dialogue.
It's not, the short thing is an ongoing dialogue, but a dialogue that must happen in a robust way. And I would dare say with some urgency, because it actually determines your underlying design of technologies. And so it's one of these foundational things that if we get it wrong, it can actually have a massively negative impact.
So that raises two questions. One that's been submitted here by one of our attendees that says, is it possible to have a policy in place which allows everyone's healthcare data, access to everyone's healthcare data under the condition that personal identification details, or PII, is not used, and maybe that would allow purpose of statistical analysis? I think it's a strong question. The other question is, who needs to be involved in just figuring out these consent management decisions? And is it the province, or then the provinces are going to have to align this to make sure that it works across the country, right? I mean, how do you figure out how big the field is of people that need to be consulted and engaged in this? Because this is all these systems are going to start interacting with each other over time, isn't that right?
Yeah, absolutely. So the in terms of the who's got to work on it, the short answer, the simplistic answer, would be provinces and territories, largely ministries and departments of health. But I'll also say there are some research organizations across the country that are looking at it. I know Statistics Canada is looking at this. This is an ongoing question that is seized at both local organizations and pan-Canadian organizations alike. And so it's just, what's important, I think, in that space is for those groups to be working together such that we can actually understand this is what the outcome of those consultations are, and this is how we're now going to start to embed that into practice. And having some overarching principles across the country will certainly help. That will allow provinces and territories to align to it. But also, I think the bottoms up, quote unquote, bottoms up of having the provinces and territories work out, well, this is what we're hearing from our constituency. That'll help them understand how to contextualize whatever has happened and is discovered at the pan-Canadian level. So I think that this is too big of a space for, I think, anyone to carry the ball on it. But I think understanding who are all the ball carriers, so to speak.
I guess my question, Eric, is I could see a situation where, where the doctors, and I'm speaking hypothetically here, I'm not casting aspersions on any one of these groups, but that the medical association doesn't want the chiropractors association to have access to everything, and the chiropractors don't want, someone else to have access to things, and that the the midwives don't get the same access as the obstetrician. So how do we? That's a really complicated set of questions here.
And simply, yes. And actually, those are really, really interesting. And then I'll even add another question on top of that, which is from a medical practitioner may say, well, my patients, they can get access to their data, but I would need at least a couple of day delay so I can contextualize that lab result, see it.
Yeah.
Yeah.
And so, I mean, Derek Green has posed this question saying specifically, this sounds like there's too many stakeholders, too many levels of governance and agencies to get them to work together, potentially. How do we get them to work together to build a national patient identity program? It's 2019 and we're far behind. This is his note on the end of there.
Yeah, so so we're far behind, and I think the way we have to start is knowing that this is a giant ball. To actually get all of them to work together, we could be waiting for 30 years. I think what's most important is for us to start. And so in that context is what is a relatively small group of organizations that can actually agree to collaborate together to actually work on this, show the value of working together on it, and then expand from there. Yeah. I think we cannot try the big enchilada solution, while fantastic, is going to be really hard to organize. But I think part of that is also if we have a set of overarching guiding principles around some of this, especially the foundational stuff, especially around identity, I think it's going to really help move the ball forward. So I guess there's two things in there. One, tactics of small group of organizations working together to actually come up to agreement on a practical implementation of something. Mm-hmm. And then second thing is that across many organizations having a guiding set of principles around, well, for example, patients own their data and there should be a way for a patient to be able to access their records easily from any system in which it exists. Yep. As an example, not advocating that specifically, or maybe though personally as a member of the public, I might. But to the in that context, it would enable a patient to get access to all of their records, and then presumably after they have access, then they can actually share that back out.
Right.
Yeah, because a patient should have the right. And so maybe this is the overarching question. Does the patient have a right to share their chiropractic records with their naturopath, with their primary care provider, and amongst all of them? Yeah. And if a patient has the right to do that, then why are we having any more conversation?
Yeah, and I think, the way that we are envisioning at Simio from a patient trust framework, from a consent management perspective, a patient should have the ability to control which healthcare provider has access to their data and who does not. The same way they should be able to manage which application has access to the data and which does not. Okay, good. Just the last point here in terms of the patient trust framework is, the ability to unlock digital healthcare opportunities. And this is more for healthcare organizations and patients, and for, healthcare organizations digitizing some of this information, having a verified patient identity that's tied into the health data that, a patient has the ability to manage consent and permissions. For healthcare organizations, you're really unlocking the ability to digitize intake, scheduling, wait times, also remote patient monitoring. And for patients, having all of this data really unlocks their ability to manage chronic conditions, enable provider-based communications, and really, step up the patient engagement that's currently in place, which is, not digital right now.
What I'm clearly hearing is that while there are fears that, if we give that data to the patients, it's going to overrun the health system with asking about all sorts of minor conditions, et cetera. But in a practical sense, what some organizations, like specifically, I'm thinking of .health, yeah. I've listened to a talk by their CEO last week, and saying that actually patients are using the system less for minor conditions and going into appointments better prepared and better educated and having a more meaningful conversation with their providers. So it's actually improving the care of the patients by usage of these digital technologies. Yeah. And while that's one anecdotal situation, generally speaking, it feels like it's right. I think more studies need to be done in that space, but it's really what the promise of digital care is, that if we empower patients and they become more educated and not only improving their data and analytic literacy, but also improving their health literacy, yep, then actually they're empowered in their own care and they can start to make the choices around how to improve their care as a whole. I actually reflect that in Ontario, for example, when we go to a fast food restaurant and you see the calories posted on the menu, it impacts my choice about what I eat. I miss that, yeah, when I go to other parts of the country, and Lord knows when I go south of the border. Yeah. But that's empowering me as an individual to make a decision. Yep. So that's an example, and certainly not digital, but there's so much more we can do from a digital perspective, because it can integrate not only personalize it for me and my health record, but also where I am at, everything that's happening, and actually say, this is what's going on, and I really should go inside, get out of the sun, and get a drink of water, because it's really hot outside.
Nope, completely agree. And you know, Eric, that's a good way to kind of wrap up, at least on this conversation, and open it up to some QA. But, you know, from Simio's perspective, we're really seeing the patient trust framework as the ability to empower patients and give them the ability to leverage these digital healthcare opportunities.
Yeah, the one thing I would add to the framework, if I can suggest, is actually having a feedback loop to the patient. Yep. Which is specifically, who has access to my record? I go to the Finland example. Yeah. Because you can actually have a fairly open system. If everyone knows that the patient can see who looked at my record and actually question why that person looked at it, yep, well, it opens things up so much, because now everybody knows, oh, somebody is snooping and I can catch them. So, yep, or if I am snooping, somebody can catch me. Yep. I will choose not to take that risk.
Perfect. Thanks so much, Eric. And Aaron, thanks so much for hosting us. Is there any questions that we have, Aaron?
A couple others that, and I think we should go back first to one of the questions, which was like, what about the opportunity to, you know, for the better good of everyone, to be able to, you know, get blinded, non-PII'd data, so that, you know, we can all benefit from statistical analysis. Is that?
Oh yeah, that for that perspective, that's just having a practice around de-identification or anonymization, which are similar topics, and doing that consistently. And there are many organizations and provinces that have fairly robust frameworks in that space. There are some challenges with it, because there's the direct person identifiers, my name, address, etc. There's the indirect identifiers, like my birth date and my postal code, that together can actually be identifiable. And then there's the stickier world of genomics, which arguably you have to render the record there from a genomic perspective, but can clearly identify me as an individual. So there's multiple levels in that, but there's clearly frameworks that can exist in that space. There's actually a group called Canon, the Canadian Anonymization Network, which is just kicking off its work, and it's a public-private partnership, and not specific to healthcare, that's actually trying to develop some common best practices and leading practices in this space across the country.
Interesting. And then the other question on this is a bit more specific. Well, we got said, you know, given the prevalence of faxes and the requirement to accommodate paper-based workflows, that's being a real problem for digital medical management solutions. And the person was asking, you know, if we would only ban the fax, it might accelerate the adoption of digital identities across providers, so that, you know, individual pharmacists, you know, can't get away with not logging into their PMS systems. The NHS has banned the fax. Why doesn't Canada?
I would be happy to put a poster in my lawn. You know, it's election season coming up. I simply said, "Axe the fax." Yeah, I love that. I have heard that clearly. There's a movie from a tragic event that happened in Alberta called Greg's Story, where an individual died because the wait times between appointments was lost. And throughout the movie, as you watch it, it really, if there's a villain in the story, the villain is really the fax machine.
Yeah.
Because it just keeps on going through paper-based back and forth. I think that is again, it goes back to what is an overarching vision and set of principles for the country. And if we have an overarching vision that says we will end faxing between offices by 2022, that would be awesome.
Yeah.
So I would personally be behind that, but it's getting those overarching principles and design really in the provinces and territories. But I think individual organizations can say, I will do my part to commit to this. So there's a bit of bottoms up that can happen as top down is happening as well. And frankly, for the public in as well.
Yep.
This has been a phenomenal conversation. I really enjoyed, and Eric and Bowers, I can't thank you enough for giving us your time today to walk through this. I've got a whole bunch of action items and things I want to read more on. I'll leave it with you to close this up, but I can't thank you enough for taking us through this today.
Yeah, no, Aaron, thank you for having us, and thank you, Eric, for sharing some of the work that you're doing across Canada. I think it lends really well from an identity and access management perspective, and the value of that identity in empowering and driving digital healthcare across Canada and North America. Thank you, everyone.
Thanks, everyone.